And we are recording the session.
Oh, hello everybody. Sorry for the few technical snafus, but I think now we're up and running here. It's nice to be here with you all. And definitely I want to be a resource for you. So if you say something, pop it into the chat, stop me. I have so many slides I have to actually change sort of halfway through, but again, I want to make this useful for you and helpful. So COVID-19, vaccines, is this the only way out? I think what we could do is just go through some of the quick updates in the epidemiology, this pandemic, then talk about some of the disease manifestations. And I did put in a slide there on oral health, oral manifestations. Then look at some of the vaccines and the technology that hopefully will help get us out of this. So as you know, the virus broke out in Wuhan, China, SARS-CoV-2. Where exactly did it come from? We think of this as a zoonotic infection. It's found in bats primarily, but also appears in pangolins. Could have been an intermediate host species, and then it jumped to humankind, and here we are. In some ways, I think it's kind of our fault, not being good stewards of the environment, the natural world. And this does bring up the concept of One Health, which is really that interface between human medicine and animal health. So some of us have sort of pointed the fingers, and I think rightly so, when you think about what we're doing to the planet. And certainly there's more to be said. As you probably know, the Chinese Communist government has scrubbed the ground zero site, so we're never really going to get all the answers, but I think it just means that we have to do better as a humankind. This is the electron micrograph of the coronavirus, this vicious, nasty virus. I think what's interesting is they've colorized it, but these are actually so small that they don't have a color because the wavelength of light is longer than the size. So you need an electron beam to see those. But this is one of the coronaviruses that has sort of plagued humankind in the last couple of decades, going back to SARS-CoV-1, the original SARS in 2002, 2003. Luckily, we shut that one down with quarantine and sort of good old-fashioned protocols. And wow, thank God people wore their masks then, because this one, SARS-1, is about 10 times more virulent. So you can imagine now the numbers we have, just multiply by 10 if that thing got out of the box. But luckily for humankind, we did what we were supposed to, and it was kept under wraps and has gone extinct. But then in the Middle East, we had another coronavirus breakout, and this is still kind of there smoldering. It is a bat virus, and it looks like camels are the intermediate host, transmitting it to humans. So that's something to watch, very dangerous. And then, of course, the current pandemic. And what I think is interesting, why don't the kids have real problems with the disease? That's because there's a lot of these cold viruses, if you will, circulating, and there probably is some cross protection. You think of the daycares, you send your kid there the first day, they come back, they're sick. So, thank goodness that the kids are not really affected as the way the adults. I think that would just magnify the tragedy. But we know a tremendous amount of information now about the virus. This is a schematic showing you the cut through the particle and the spikes, which you've heard about, these proteins on the surface that resemble the crown. And there are other proteins that we know about, sort of targets, if you will, for future therapeutics. We know a lot about the life cycle. You can see here the diagram. The virus comes in. It likes to bind to the ACE2 receptor. Then it comes inside the cell, and then the virus essentially takes over the cell and produces more copies of itself, and then will come out. So all that means transmission. You have people who are infected, coughs, sneezes, even speaking. So it's good that I'm safe here from my computer terminal without the mask. But I think we have to be real. And looking now at what's going on across the states, I mean, we can't really let up on this thing. Some of the state governors rolling back common sense interventions like mask wearing. I think you have to be smart about this. So COVID-19, that's where the name comes from. The Chinese told us fever, dry cough, shortness of breath, but we learned kind of the hard way that it's a lot more than that. Everything in sort of the flu-like category, including loss of taste and smell, that's about a third. Even neurologic symptoms, confusion, dizziness, particularly affecting the elderly. In terms of oral health, these are the sort of top 5 symptoms that I think you might encounter. Number 1 is actually the gingival inflammation, and certainly it's non-specific for some infections, but we know that ACE2 receptors are well presented all over the body, and particularly in the mouth. So it's certainly inflammation of the gums. Xerostomia, dry mouth. That's because guess what? The salivary glands also are highly represented with the ACE2 receptors, so there can be effects of the quality of the saliva, that sort of thing. Certainly ulcers. You've got a nice picture here of sort of a breakdown there. Cracked teeth have also been described, and I think partly that deals with the stress, and that's sort of the second aspect of this pandemic, is just that it's not just the actual disease, but it's all the knockoff horrible consequences, people losing jobs, income, childcare. It's just an absolute nightmare. Loss of taste, the agousia, dysgeusia, loss of smell, I think we know about that as well. What to me is very, very concerning is the inflammatory nature of this, and particularly in regards to the endotheliitis, if you will, the inflammation of blood vessels. Again, blood vessels are have high amounts of the ACE2 receptor, so you can get a lot of virus attaching there and get some localized inflammation. So seeing things like DVTs, blood clots, arterial clots, strokes in the younger people is certainly a major concern. Where the kids do get involved is if they have a Kawasaki-like syndrome. We call this MISC-C, multi-system inflammatory syndrome. Luckily, it's extremely rare, but it's something to watch out for. And definitely this pandemic, as we learned kind of the hard way, has a whole spectrum of illness. That mild, moderate, did we really see that? It's kind of like that proverbial floating iceberg. Certainly in the spring, we were only seeing the severe cases, but now we have a lot more knowledge about the asymptomatic and mild illnesses being a real problem. You think about what diseases, underlying disease conditions might make things worse. And I think that's partly why here in the U.S. we've had such a tremendous problem, because our general health has not been good. And, looking in the mouth, I think that's sort of a window to a patient's health, knowing what sort of health conditions they have. That's sort of the first thing that, I train my students and residents to look in the mouth, and I'm sure all about it. But definitely there's risk factors, obesity, diabetes, underlying health conditions that you can see here. Where are we now? Well, certainly across the U.S., tremendous problems, more than 28 million cases. We crossed the 500,000 death toll last week, and it's pretty amazing to see that we're still just accelerating onwards. And it's not just us. I mean, we are the top country in the world, but certainly other countries have been getting hit. You look at Europe, you look at Brazil, just tremendous casualties. I do want to highlight the Johns Hopkins website. It's extremely useful for updates, and they do have a 1-minute video that they update every every day, and you can see what's going on. This is just a screen capture from that, showing you where some of these hotspots are for disease. This is the case data, and it's presented by the New York Times. I kind of like their format. And you can see that after January, things dropped off quite precipitously, but the key is this decline has now stopped. So I think that's very concerning. It still means lots of disease that we're enduring and plenty of deaths. One way I represent that is jetliners. How many jet planes have crashed just today when you think about it? And certainly each death absolutely is a tragedy, but I mean, this is just a massive, massive pandemic with huge repercussions. This is the death toll. You can see the dark black line is sort of the rolling average of deaths, and it's still very significant, very sad. So this is just a quick case I wanted to show you. I thought it was representative of what we've been seeing in the hospitals. 61-year-old Hispanic, diabetes that wasn't controlled, obese, a few other medical problems, blood pressure, cholesterol, thyroid. He worked as a chef in a group home. So, which came first, the chicken or the egg? But then he developed this respiratory symptoms, cough, shortness of breath, some myalgias, nausea, vomiting, and sure enough, tested positive. Oh, by the way, his wife had it too. And when he presented, he wasn't really looking good, a little bit tachycardic, tachypnic, saturating quite low. And, some of the telltale markers on his presentation, you could see he was lymphopenic, his inflammatory markers were up, his sodium was low, he was a little bit dehydrated, and certainly his blood gas didn't look good, he was hypoxic, and that's his chest x-ray. So there's almost nothing left there in terms of functional lung, and of course he went to the ICU. That's when I got involved in his case. Required high levels of respiratory support. That's his CT, a little bit better resolution of the lung disease. You can see just how horrific that really is, all from a virus. And unfortunately, the patient passed away. So I just now have to load up my other slide deck here, part 2. So I don't know if there's any questions at that point or commentary.
I do not see any questions in chat, so I think we can let you go ahead as soon as you're ready to go.
Great. Well, thank you, Gary. So moving on here, the pathophysiology. Can you guys see that? Okay, good. So we know a tremendous amount now about the disease, and looking on the left side here of the slide, you think of a viral infection, the virus coming in, attaching to the ACE2 receptors. What do we have sort of antiviral in terms of medications? I'm sure you've heard about remdesivir, that kind of thing. But with this disease, we see that things progress, and after about 10 or 11 days, the virus goes away. And the disease then is more manifest as inflammation. And for whatever reason, this is a stimulatory virus. We get all these problems with too much inflammation, and that's when the patients really get into problem. That chest x-ray I showed you, wow, I mean, that's ARDS, it's just overwhelming. And that's unfortunately what's causing the patient to have such morbid outcomes and mortality. So when you hear about the steroids, that's when those are most important, is more for, tamping down the inflammatory part when the immune system is going haywire. But we do have oxygen, and, do we think of oxygen as a drug or a medication? Maybe we need to think that way, because actually, I think that's the most effective and most helpful therapy that we have, and we've got all kinds of different ways of giving it, from nasal cannula to masks and, of course, machines. Remdesivir, I'm sure you've heard about that. That's an adenosine analog, so basically interferes with the RNA of the virus and kind of messes that up. Is it a great drug? No. Is it okay? I'll take what I can get because we're still waiting for better medications. But viruses are hard to make antivirals for. Bacteria are much easier to look at this complex bacterial organism and attack certain features of it, but it's much harder to make a antiviral. We do have monoclonals that I think have been somewhat underutilized, and maybe in the outpatient setting you might find a role for that. There's two companies that make them, and they have complex, dreadful names. But essentially, for those patients who are not sick enough to require hospitalization, these can be given with actually pretty good effects. Comparing the placebo versus the treatment group, there was a definite benefit in terms of giving these out. Of course, they're injectables. Might there be injection-related side effects or, God forbid, anaphylaxis? Extremely rare. But whenever you're injecting something, maybe even just lidocaine into the mouth, you have to be prepared, know where your epinephrine is, just in case. So I think part of the problem why you didn't see more of this usage was we were just overwhelmed. We're still overwhelmed. But I think now we've got a little bit more knowledge here. And, if you do have cases, it might be helpful to try this before they get too much sicker. So prevention is huge. Masks, I love masks. Even a simple surgical mask does a very good job. Of course, the N95 being something of a gold standard, but it is hard to breathe with, and you get that impression on your face. Other practical things, which I think we know about, and hopefully you're all well versed on the PPE. If there's any questions, I think the real issue with PPE is taking it off, not to contaminate yourself. Just to be mindful of that just to think of things as contaminated, and to reach for the hand hygiene if you think you might have contaminated something before you self-inoculate. Vaccines, wow, Operation Warp Speed, getting vaccines developed, kind of like going to the moon within a decade. I mean, this was absolutely phenomenal. I know there was some pushback about safety, but I trust the science, and, thank goodness. So many candidates were sort of into the race. How many actually came through? If you look at the WHO website, they have a whole page on this. It's pages and pages of the candidates, and pretty amazing looking how, all of medical science was just working on this, and I think other diseases and illnesses were sort of triaged away. But thank goodness we have tremendously good vaccines. The first that I want to talk about is the mRNA vaccines. Basically, it's a simple concept. You get mRNA, you wrap it up in a lipid envelope, a coat to sort of protect it because it's an unstable molecule, and then you inject it in. This actually doesn't go to the cell nucleus. It just gives instructions to the protein manufacturing components of the cell to make spike protein. And the great thing about an mRNA vaccine is you can micromanage, you can adjust things. So with the variants that are coming out, do you need to adjust that? You absolutely could. Easy to do. And then once the cell makes these proteins, the immune system is like, oh, this doesn't look good. Let me watch out for that. And it develops a immune response. The mRNA vaccines are very robust. They seem to be stimulating both the T and the B cell arms of the immune system, including B and T cell memory, which is very good and helpful, and absolutely great. I think part of the downside is that the ultra cold storages was something of an issue. But now, just this past week, we've had the J&J vaccine approved, which is actually a modified adenovirus. And if you know, adenovirus is actually a DNA virus. And kind of like Legos, they took a piece out, put a piece in. That piece encodes for spike protein. And kind of like the same thing, it's being injected. It tells the cell, hey, make some of these proteins, the spike protein fragments, and then the immune system has something to work with, and it can develop an immune response. So this was the Pfizer vaccine, huge trial. These are some of the demographics and some of the quote unquote, I don't call them side effects anymore, I call them effects, because it's definitely an immunogenic product. That's actually what you want, is to get a little bit of a response. And some people complain about it, but when I got my doses, I didn't feel that great. But you know what? Very huge relief to have that protection, and phenomenal if you look at the numbers. There's some real-world data behind the Pfizer shot, looking like it's extremely good. And thank goodness, I'm glad it's not like the flu shot where you're kind of hoping that you get some immunity, with all due respect to flu vaccine. But a little more detail about the J&J vaccine. If you look at some of the numbers, you might think, oh, well, geez, it's not quite as good as the mRNA vaccines. But thinking about it, it essentially does the same thing, which is getting genetic instructions into the cell, producing spike protein. Then the immune system says, hey, that's not good, let's respond. Obviously, since the trial was done at different place, different time, you see different effectiveness. Certainly the one and done attribute of this, the fact that it doesn't need the ultra cold, just refrigerator will do just fine, I think has certain advantages to it. And very thankful that we have a third product. So what can I say more about that? The efficacy numbers, not quite the same as Pfizer or Moderna, but there's no actual head-to-head comparison. And those prior to Pfizer and Moderna, those were tested at a different time when you didn't have these problems of variants popping up. So the variants, that troubles me a little bit as an immunologist, infectious disease doc. And Dr. Walensky has said, you know what, we got to just keep going. You can't be repealing these mask mandates and things like that because we're not out of the woods yet. And what it's looking like now is the B117 strain is going to take over later this month. That's the predominant strain. And while you have uncontrolled pandemic, as we still have now, you're able to generate more mutant variants. And we just found a new one in New York. It's too early to tell the virulence or lethality, but remains to be seen. This is a slide from the CDC just showing you some of the problems with the variants. This is for the B117. You can see that 46 states are affected, more than 2,500 cases. And this is the B1351. Much less, thank goodness, but it's out there. A large number of states are affected. Hopefully we're continuing to immunize. I like this map because it shows you the sort of the end goal that we're trying to get to, two doses in. So the darker blue would be better. And this is for Missouri. So if you go to the website, you can actually click on your state and get the latest update. So total delivered 1.7 million, 1.4 million administered. You can see there that we're making progress, and hopefully now with the J&J, we can get more immunizations. So continuing on, common sense. Are we going to get rid of this? I think obviously the mutants, the variants is an issue. Trying to wipe out some of the reservoirs, and that includes elsewhere around the world, because we have vaccine, but we really need to get everybody with this to just shut it down. And that's it. So I don't know if there's questions or commentary.
I do not see any questions in the chat. If anyone has any, please pop them in there and I will pass them along. Oh, wait a minute. Lori Crawford. I'm curious to see how COVID starts spreading again since states like Texas are fully opening up and not requiring masks, especially with the new strains. Yeah.
I wish these people would take some lessons from public health. I mean, I know it's important to get your business back open, but we're still going to be struggling until we get control of this thing, and we still do not have control. I mean, luckily, the rollouts of immunizations are ramping up, and some days we're actually getting 2 million doses in a day, which is phenomenal. And maybe by the end of May, every adult will have been immunized. But that really is the only way out, is to get the immunizations in. And until that happens, you got to be smart. So my heart goes out to those states that are being misled. It's too bad.
We have a question. What about pregnant women taking the vaccine?
Fantastic question. I'm glad you asked. Most pharmaceuticals shy away from enrolling pregnant women in the trials. There have been animal studies done for Moderna that showed, at least in pregnant animals, there was no safety signal, and there was sort of a realization that during the trials, some people actually got pregnant, and they've been following those women. It's a small number. It's 30, 35 women. No safety concerns right now. I think on the individual level, that's what the health authorities are recommending, that you discuss this with your OB/GYN. I can't really make a recommendation here, but when you know that a pregnant mom could become very sick, just being pregnant is a risk factor for severity of disease. And if the mom gets sick, what happens to the baby? So those are factors to consider. And I know that, at least personally, a lot of the physicians who I've talked to and had family members, they went ahead and were immunized. So, yeah.
How long do oral lesions last? Can they come and go after having COVID?
That's a great question, and I wish I knew the answer for that. I don't really have much experience, and I don't know if anyone else on the call might chime in if they know.
Yeah, put your response in chat, and we'll try to get to it if you have one. Just someone's curious about what happened with the flu this year.
Oh. Well, I think this mask wearing and social distancing hygiene had a lot to do with it. Wow. And coupled with the fact that immunizers, we were so worried about getting hit with a flu at the same time that we were crushed. I mean, we were really crushed this winter. And, could you imagine that if we had a really bad flu year, how horrible that would be? So I think we got very lucky. What's going to happen next year? Not really sure, because the flu actually can mutate 3 times more efficiently than this COVID-19. So flu can come out with something new and vicious at any time. And in fact, the experts are really thinking that the next pandemic was going to be flu, not coronavirus. So who knew? But hopefully flu gives us another bye until we get through this pandemic now.
Based on the rate of new variants, how frequently do you think vaccine boosters will be necessary?
Great question. The pharmaceuticals are already working on boosters because, we still have tremendous numbers. Are you going to see boosters come out in the fall? I think you are, particularly healthcare providers. I mean, we're not going to be getting a break anytime soon, and, pockets of disease. They're already working on it, and great. And that's what I love about the technology. That mRNA, you just adjust something, put it back in, do a quick safety thing, and you're done. You get approved. So that's going to be quick and easy. I feel good about that. And, hey, there were some good things that happened with the pandemic. Vaccine technology got a super boost, just like going to the moon. I'm happy about that.
That's great. Why do young adults have a more severe reaction versus elderly after vaccination? Please keep yourself muted if you are not speaking.
Sorry, there was an overhead page there, but
oh, that was you. Okay.
Yeah. Well, they're paging again. All right.
May I have your attention, please?
Sorry.
Internal medicine.
That's okay.
Okay. Young people, it's great to be 19 or 21, and that's because you're in your prime of your life. I mean, I hate to think of how old I am, but when you get an immune stimulus, you respond better. So certainly there can be some would you call it increased effects of the vaccine just because they're responding, as opposed to someone who's 80 and their immune system as well as every other body system is in decline and just doesn't respond as well. We call that immunosenescence, when your immune system weakens with age. So I think that's partly what you're seeing.
Yeah. There was a comment that even in rural areas of Missouri, people are not following guidelines, such as the Hannibal, Missouri area, or that would be the northeast area of the state. Yep, I've seen that myself. It seems to be pockets where there's an opinion that masks are political and they don't need to be worn. And I've been in that area of the state and saw that. Can you comment on the lack of outbreaks seen in the dental setting? Can this be attributed to the efforts of increased PPE used in the dental setting, or could it be because of lack of reporting/tracking?
Well, I think my colleagues here, you're much more tuned into the mouth and the nose and all that infectious thing. So I think credit goes to you guys for sort of figuring that out early. So I think definitely that has something to do with it. Certainly reporting, I mean, part of it's our fault because, what did the Chinese say? We weren't really thinking that sort of cold-like symptoms could be COVID, but absolutely we learned the hard way that it was, and that asymptomatic, quote-unquote, transmission was really a thing. So, I think it's multifactorial.
Is the J&J vaccine safer for persons with prior history of anaphylaxis or allergies in general?
That's a great question. It's a different formulation. And, if you're really concerned, you want to go through what sort of past allergies you've had. In the J&J trials, there was no anaphylaxis. PEG, polyethylene glycol, seemed to be the allergen for the 2 mRNA vaccines. So if someone had a problem with PEG, that would be an issue. But again, it's extremely rare. If you do have that history of allergy, talk to your provider. Hopefully it's not you, but luckily the numbers are extremely low.
If someone is taking an ACE inhibitor, are they less likely to get COVID?
Great question. We don't really know the answer to that because it's just too complicated. Modification of the distribution of ACE receptors. I mean, I know there were some statements from the AHA, American Heart Association, that came out early. They said don't mind that.
Okay. I have read through some of the articles online which say that there are side effects like anaphylaxis and neurological complications. I am not sure about the relevance of the data. Do you have thoughts about it?
I think, again, it's benefit versus risk. You could die from this easily, particularly if you're older or have morbidities, and you don't want to be the one bringing this home to somebody else in the family. And certainly we've seen those heartbreaking clusters. Some of those made the news, like the wedding in Maine that so many people were affected and deaths resulted. So, yeah, I mean, everything has side effects. If I cross the street, I could be hit by a car. But, getting the vaccine, I think, is absolutely huge. And that really is the way out of this pandemic, because either you get it or you get the vaccine and get protected. That's really it, I'm afraid.
Someone says, this is perhaps an ignorant question. I doubt it. But when you talk about more infectious strains / variants of the disease, is that more infectious in a world with no precautions taken, mass social distancing, etc.? an ideal one with all precautions are in a model, and how exactly is that measured?
Well, that's a great question, and I think in some ways it's a thought question because, nature does its thing, and just when you have a new organism of any kind sort of appear, and I think, mammals after the age of the dinosaurs. I mean, here we are. If the dinosaurs didn't get wiped out, we would not have evolved. So certainly evolution of viruses, and until now there hasn't been that much pressure on them. I mean, now we have vaccines, so in some ways that's going to shift the population of viruses to go around those. That's just nature doing its thing, just like medication resistance for bacteria, antibiotics. So, what are we going to see coming down the pike? I'm really glad the vaccine technology has accelerated because I see that as sort of the answer to what nature is going to throw at us, because we know there's going to be more mutations, and hopefully science is going to be one step ahead. Right now we're one step behind, so we still have to do some catch up. But hopefully, as the numbers drop down, hopefully maintaining the common sense things, we can get a little bit better control and start to win.
Okay, there is a comment and two other questions, and I'm going to stop you all there because I think we could probably go about 3 or 4 hours more on this with your level of expertise. First, the comment responding to the question about dental practice, and the statement is, I think in the dental setting, we've made changes, I believe is what is being said. Since we are now screening patients beforehand, we are not seeing patients who are sick or even have a runny nose. Hopefully, I'll never again hear, come on in, we wear a mask. So probably a very good point. I am not a dental practitioner, but from my perception, I would say things have changed very quickly and very dramatically in day-to-day operations of dental practices. So I think Lori Crawford has a good point with that, my humble opinion. Is there a link between blood type and ability to contract COVID? Urban legend or real?
Well, unknown. I think in some ways it's a urban legend, but I mean, blood types, there's only a few of them to begin with, at least for the major blood groups. But nothing has really distilled out from that. The genetics of the human genome are extremely complex, and it seems true, but unrelated. So unfortunately, it's not really a thing.
Okay. And then our new state dental director, Dr. Jeaton, gets the last question. Since we haven't vaccinated 80% of the population to reach herd immunity, to what do you attribute the steep decline in new cases in the last 2 months?
That's a fantastic question. I think actually we might be seeing localized herd immunity because the people who didn't follow the directions, who didn't wear the mask, didn't do this and that, they all got sick, whether it was major illness winded them up in the hospital or, mild sort of stay at home, feel miserable, or even asymptomatic. So I think actually the virus has burned through a lot of the population, and now you're seeing the resistances because you've got new strains, and maybe some people are coming out of hiding. Like I don't know if I should call it the Texas governor, but don't let up until we're done. And I'd really love to see these numbers drop further, but I'm worried that we might start to go back up again in terms of the numbers because you can't trust a virus.
Well, Dr. Sholin, I want to thank you for an absolutely outstanding presentation. I wish we had allotted more time for you because it's really been very, very interesting, and appreciate you sharing your expertise with us. Really, really excellent.
Well, it's a great honor, and you've got my contact info if you ever need to reach out. I'd be happy to take more questions at some time later, but thank you so much. It's been an honor for me to be here.
Great having you. Again, the slides will be available on our website, and there will be a recording of this presentation on our website a little bit later. For those of you wanting CEUs, the code is COVID, COVID. Pretty pretty predictable CEU code. The link to the CEU survey is on our website through close of business Monday, so get to it quickly if you want to do that. And could you stop screen sharing? Thank you. Very good. Thank you so much. Have a great
Take
day.
care. Take care, everybody.
So we do have another exhibitor focus here. Ashley, are you prepared to introduce?
I am. So our exhibitor focus for this session is the Midwest Special Needs Trust. And Heather, if you're ready to screen share, you can go ahead and share your presentation.
Okay. Well, I am Heather, and I am the Charitable Trust Specialist with Midwest Special Needs Trust. I also have Bianca Farr here, who is our Associate Director, and we are very excited to be here today. And I'm going to turn my video off and see if we can get our screen share on.
We can see it.
All right. So our company has been around for 32 years. We primarily set up special needs trusts for people living with a disability, and those trusts protect their assets and public benefits. But we also have a charitable program that I'm going to tell you a little bit more about today and how we might be able to help your dental clients. Our charity covers the entire state of Missouri. Those we help do have to be a Missouri resident. They must be receiving disability benefits through Social Security and have a household income under the federal poverty guidelines. We provide up to $1,500 in assistance for items or services that aren't covered by their insurance or available through other community programs. They can request assistance for a wide range of needs, and one of those needs is definitely dental care. And as you can probably imagine, that is our number one requested need. The number one request we receive is help with dentures, and we also receive a lot of requests for root canals, crowns, and a lot of oral surgery as well. We do consider dental requests an urgent need, so we review and make decisions for those requests every month. There is an application that we have that needs to be completed. Our application can be found on our website, or I'm also happy to mail you one as well. We also need proof of income, and then we also need a treatment plan that shows what care is needed and what the cost of that need is. We are a private charity, so we do have limited funding. Unfortunately, that means we can't help everyone who applies for assistance, but we do help as many people as we possibly can. We work with all of the FQHCs in Missouri, and those sliding scales definitely help us spread our funds a little bit further. Some dental offices offer discounts as well, which helps. If your client does apply for a grant from us and does not receive one, they are allowed to reapply. So just keep that in mind. When a client receives a grant from us, they receive a letter as well as the dental office. The dental office, though, receives a letter that's signed. It's a signed agreement stating that we've approved a grant and the amount that was approved. I also send a copy of the treatment plan that we received, so you know what care was requested and approved. Sometimes dental care changes, and so we can change the need that's approved, but we can never change the amount that's approved. So just keep that in mind. The grants do expire after 6 months, but if your client needs more time to complete the dental care, we can certainly extend the grant. Just call and let us know. We've done a lot of that, especially over this last year when dental care, has gotten to be really hard to get, and then people are trying to make up those appointments that they missed. So that is certainly something we can do, but we like to get them done within 6 months if possible. Payment is made after the dental care is completed. This works well for the dental offices that we work regularly with, but if you're a dental provider that's never worked with us and you're hesitant about not getting payment up front, we can certainly work with you on that. And payments are made directly to the dental provider by check. We never go through our client and rely on them to make the payment. We send the payment directly to the dental provider. If you would like more information, the email on here goes directly to me, or you can send us a message through our website. Our website also has some more information on our program and also information on how you can donate if you would like to do that. Our program is set up that 100% of donations we receive go out to the people that we serve. So we never keep any of those donations for administrative costs or anything like that. 100% of them is used to help the people that we work with. So I'm going to turn off my, sorry. And we really appreciate the time to talk to you all today and commend you for all of the good work that you do. Thank you.
Well, you too, Heather. Thank you so much. Midwest Special Needs Trust is really a unique organization and provides a lot of support. So really appreciate you being here and supporting the coalition and working to improve the oral health of Missourians.
Yes,
Great. And as promised, we are not giving you